Regarding pediatric fractures, pediatric femoral neck fracture, proximal femoral fracture is classified by Delbit. Type 1 is a transcervical, transepiphyseal fracture. Type 2 is a transcervical fracture. Type 3 is a basicervical fracture. And type 4 is pertrocranial fracture. As Delbit 1 has a higher incidence of avascular necrosis for about 60 to 100%, and the risk of EVN reduces from Delbit 1 to Delbit 4. Anyhow, if these fractures happen, there should be high predilection to exclude non-accidental injuries in such cases. In a young age, if there is such fracture happens, for example, if it's epiphyseal fractures, then the treatment depends on the type of fracture, the age of the patient, and how can we get the stability. In certain scenarios, for example, if the fracture is transcervical, we need to prefer to fix it, avoiding the physis. But in transepiphyseal fractures, sometimes we need to cross the physis. Anyhow, in such situations, I would prefer to go and cross the physis instead of avoiding it and make the fracture unstable, as the non-union is management of non-union is more difficult than managing limb length discrepancy on later age. Regarding the age-related treatment, I want to reduce the fracture as early as possible to avoid avascular necrosis. In less than 4 years old, I would prefer to apply hip spica cast. Hip spica cast is contraindicated if there is severe shortening, if there is open fracture, there is abdominal injuries, or very large obese childs. In more than 4 years of age, I would prefer to a short screw, 4.5 to 65 5 mm, cannulated screw, or in transphysial, I would prefer to go 6.5 and 73 mm screws. In type 3 and type 4 Delbit, I would prefer to have pediatric hip screw fixation. The problems which can happen is avascular necrosis, coxa vara, limb length problems, chondrolysis, and great trochanter problems issues, and compartmental syndrome.